Herpes virus. Herpes virus is a double-stranded DNA virus with a protein coat. It's differentiated into HSV1 and 2 by glycoproteins in the lipid bilayer. Typically, HSV1 historically is thought to be the source of oral herpes versus HSV2 seems to be the source of genital herpes, but now there's good data suggesting that HSV1 can also cause genital herpes outbreaks, but that is typically what we have thought over the years of training. Incubation period for this virus is anywhere between 2 to 12 days. It replicates in the dermis and epidermis and causes cellular inflammation destruction, and then eventually moves into the sensory ganglia where it lies dormant and then can become reactivated in recurrent infections. The incidence of this is high, so prevalence among ages 14 to 49 is about 15.9%. However, about 20% of the U.S. population of women are seropositive for HSV2. This was actually something I noted on TrueLearn. Only 5 to 15% of women who reported infections recognized signs of infection at the time. That was a report that was also published in UpToDate. So it's highly likely a lot of time patient may not know that they're positive or may not have symptoms and they're passing along to their partners. So types of infections, there are two. Primary infection is an infection without pre-existing antibodies. Average incubation time here is about 4 days. And of course, the recurrent infection is the reactivation of the genital HSV if the patient has the same antibody type. So if they have IgG to HSV2 and you do a culture or PCR showing HSV2, that's diagnostic for a recurrent infection. Manifestation, so it's pathognomonic is, group vesicular genital ulcers, sometimes with primary infections. They'll have fever, pelvic lymphadenopathy. Typically, primary infections will last longer, on average about 19 days. Recurrent infections are typically more mild. We'll have prodromal symptoms with localized tingling or shooting pain. These infections typically will last less time and average about 10 days. Extragenital manifestations we won't get into too much here, but herpes virus can also cause meningitis, sacroiliitis, which can lead to urinary dysfunction. Diagnosis again, viral culture is less sensitive. Only 50% of the time it will be positive or pick up an active infection. However, if you do this, because that's the resources that you have, make sure that you're unroofing the lesion to be able to really, really extract some of the vesical fluid. But a better test is viral PCR, which is typically what we do. The serology is a good way of determining whether it's a primary recurrent infection. If you have a positive PCR or culture and you have negative IgG antibodies, that's diagnostic for primary infection, or if you have IgM antibodies without IgG antibodies, also the same, diagnostic for a primary infection. Treatment. So treatment it should be initiated within 24 hours of symptoms, and why this is important is because if the patient particularly has had a history of herpes before, they should be supplied or have refills readily available for either recurrent therapy or suppression, so that way they can initiate therapy as soon as they find that they have symptoms. So primary infections typically are a total 7 to 10 day course. You can add additional 5 to 7 days if they still notice lesions after 10 days. And the mainstays in terms of agents for treatment are mainly acyclovir and valcyclovir that we'll see, but you can also use famotidine for episodic therapy as well as suppressive therapy. So it's really depending on the patient and the severity of the recurrences and the frequency of the recurrences, whether or not you want to provide a strategy for episodic therapy alone, giving them refills, or proceeding with suppressive therapy. The CDC recommends after greater than or equal to 6 recurrences within 1 year that you start them on suppressive therapy. And again, it's all dependent on the patient. So typically acyclovir is a little bit cheaper, but has a more frequent dosing schedule. So it may be beneficial for some patients with limited resources, while valcyclovir tends to be more expensive, but you have to take it fewer times. So it just depends on what the patient is more likely to adhere to, as well as what's available to them. In the absence of suppressive therapy, you can counsel patients that they can have an average of up to 4 recurrences per year, and that's depending on, obviously, their immunosuppressive state. Syphilis. So syphilis is the microbiology is the Treponema pallidum spirochete bacterium. This is the dark field microscopy. That's pretty much also pathognomonic if on testing. So the spirochete initiates infection by gaining access to subcutaneous tissues via microscopic abrasions. And then additionally, for women who are pregnant, which we're not going to, again, touch upon congenital syphilis today, but the spirochete can also readily cross the placenta, causing fetal disease. Incidence in 2016, 19.9 million prevalent cases in ages 15 to 49 worldwide. In 2018, the case rate was 10.8 in 100,000 people in the United States for primary and secondary primary and secondary syphilis infections. From 2013 to 2018, the rate of primary and secondary cases in women increased over 170%, and this was largely believed due to increased incidence of IV drug use. Diagnosis, so typically first-line diagnosis is screening with non-treponemal tests, either the VDRL or RPR. So these are tests that will be reported as titers, and the titers are useful to follow after treatment to determine therapeutic response. Diagnostic testing, so it's usually a reflex. If you have a positive non-treponemal test, that you want to get a diagnostic test to determine if you can confirm that there is an active infection. So you get the treponemal antibody assays. There's several of these. We won't go into specifics about the differences, but it is preferred for diagnostic testing. These, however, tend to stay positive for life, so these are not super useful if you're trying to determine if this is a case of reinfection after being treated with a prior infection or primary infection. Manifestations, so the different levels of this disease. So primary is usually a painless chancre. That's the picture here on the left of the vulva. The chancre is located here. Secondary, you may have is pathognomonic macular papular rash on the palms and soles. They have lymphadenopathy, fever, malaise, flu-like symptoms, pharyngitis, and then condyloma lata here. You'll see these papillary kind of exophytic lesions on the vulva. Early latent syphilis, is when the patient is asymptomatic and then has a positive serology, and you know that they have tested positive within a year's time. Late latent is no symptoms, and again, positive serology, but it's been over a year since the initial infection, or the timing of infection is unknown. Lastly is tertiary syphilis. So this can be pretty significant and manifests as cardiovascular disease, particularly aortitis or vasculitis. Granulomatous gumma lesions, you see on this woman's nose here, these are all gummas. These are granulomatous lesions here. And then there's Neuro Syphilis, which can cause paresthesias, tabes dorsalis, and interfere with the ocular neurological systems. 25 to 40% of untreated patients can develop late disease. So it's really, really important. That's a pretty significant amount of patients who have syphilis can go on to have these kind of more permanent or long-term sequelae of a syphilis infection. Treatment, again, based on stage. So primary or secondary or early latent syphilis, the patient only needs one-time treatment IM of penicillin G, benzathine 2.4 million units. If they have late latent, unknown, or tertiary syphilis, they're going to need 3 weeks of treatment. The same medication, penicillin G, benzathine, 2.4 million units IM. And this is a once-weekly injection for 3 weeks. Neurosyphilis that requires IV therapy. Typically, the patient is hospitalized for this. And in terms of monitoring for adequate response, if you see a decrease in non-treponemal titers fourfold, meaning if they had 1 to 32, now they're 1 to 8, or 1 to 16, now they're 1 to 4, so that's an adequate response after treatment. So again, these are your VDRL or your RPR titers are decreasing. Loss of antibodies over time after treatment or seroreversion is considered a clinical cure. So I'll talk in just a second about how long you monitor patients. So once their non-treponemal antibodies become negative, then you know that they're completely cured. One thing to bring up is the Jarish Herxheimer reaction. So I think I've had no short of 2 questions so far I found on TrueLearn regarding this. This is after the patient's treated with penicillin. Syphilis can cause release of inflammatory cytokines. This can manifest as hypotension, uterine contractions, myalgias, headaches, decreased fetal movement. So it's important to actually to manage these patients in the hospital. They should have fetal monitoring before and during treatment if they're after viability. If they're not viable, then they don't recommend inpatient management. They can be managed outpatient as long as there's no complications. The whole reaction is self-limited and resolves within 24 hours. Just keep it, that in the back of your mind when you're counseling your patient, that this doesn't last forever. And it's just a side effect of treatment. So again, how often do we have to monitor patients? Patients who have early syphilis should be retested at 6 and 12 months after treatment. And then typically these patients will have what quote unquote adequate response within 12 months. Late syphilis sometimes takes a little bit longer for an adequate response to be seen. So they should be retested at 6, 12, and 24 months. And at times they require the full 24 months to see that adequate decrease in non-treponema antibody titers. Once the RPR titers have become non-reactive or negative, no additional testing is required unless you're concerned for reinfection. If the patient is serofast, meaning they received an adequate response and saw that drop in their antibody level, but they have not become non-reactive, then they should be retested every 6 months for 1 to 2 years to make sure they're continuing to be stable and that there's no signs of reinfection or a secondary infection. Once you get past the 2 years mark of every 6 months of screening, then they can move them to every year screening. Again, that's serofast, meaning that they've had adequate response, but their RPR levels never become non-reactive. And here are my resources. So a lot of information I received from the CDC website for STIs. So definitely a really good resource if you're looking for more specific information. The Practice Bulletin on Management of Genital Herpes, it has a lot of good information, as well as the Committee Opinion on Expedited Partner Therapy. And thank you very much. Good luck, everyone.